Okay, so today I want to talk to you about chest pain. I'm Stephanie Costa. I'm currently the 2023-2024 MD5. So I just wanted to give you this presentation. It does include some EKGs from Life in the Fast Lane, and we'll go through and discuss them all. If you have any questions after this lecture, feel free to reach out. So why talk about chest pain? A lot of times chest pain can seem like nothing. It could seem like easy, smooth sailing, patient's not in any sort of danger. However, then you look a little bit deeper and you see the careening waterfall. So let's talk about typical chest pain. Typical chest pain has historically been defined as like left side of the chest with various terms to describe the pain. Some people say elephant sitting on their chest. Some people say they just can't breathe. Some people say sharp pain. A lot of people describe pain in different ways. A lot of people with chest pain also note that the chest pain goes away when they rest and gets worse when they exert themselves. They also note that pain radiates to the arms, shoulders, especially the right arm. The right arm is more indicative of a cardiac issue than the left arm when you look at the statistics. But if pain's radiating somewhere, your level of concern should also go up. And other symptoms of typical chest pain include diaphoresis, dyspnea, nausea, and vomiting. Atypical chest pain is a little bit more subtle and a little bit more hard to pick up. Some keywords that a lot of people use to describe atypical chest pain include this chest pain that's been going on for days. It changes in pain quality when they move. So when they reach up to get something in the back of their car, they know that the chest pain gets worse. And you have to be very much aware that everyone doesn't present with that crushing chest pain. A lot of people with um, this atypical chest pain may just have nausea. So a lot of the people that we see every day, including women, patients in minority groups, elderly patients, patients with altered mental status or psychiatric conditions, and patients with diabetes may not present with that classic left-sided chest pain, pain going down the arm, crushing pain. This was because most of the original chest pain studies were performed in Caucasian males from in a certain age group, so they didn't include women or many other of our patient populations in those initial studies. So it's very important to have a high level of suspicion anytime anybody has a complaint, basically from their neck to their pelvis. On physical exam, there may be no physical exam findings, but your level of suspicion should be increased if somebody is very diaphoretic, if they're hypotensive, if they have a new murmur. Any of that stuff is concerning, but also somebody just saying that they have chest pain, upper belly pain, trouble breathing, just get an EKG. So let's go through some scenarios. Um, in this first call, you get a call for a 20-year-old male with chest pain. He says the pain just started while he was lifting weights. He thinks he pulled a muscle, but he's diaphoretic. And then he tells you his pre-workout's cocaine. So this patient definitely deserves an EKG. I know that it's a little bit off-putting that he's 20 years old. However, um, cocaine does increase your atherosclerotic risk. So these people are developing cardiac disease from their cocaine use early. And just because he was lifting weights could easily trick somebody into thinking that it's not a cardiac event in nature, but it's just safer to get an EKG. In scenario two, we have a 40-year-old patient with nausea, vomiting. They think they ate some gas station sushi yesterday. They look okay. When you start taking the rest of their history, they got diabetes, hypertension, asthma. They take metformin, insulin, and they smoke cigarettes. So in this patient, their diabetes may be masking chest pain, and their cardiac issues may be presenting just with nausea, vomiting. So having that high level of suspicion, this patient should also get an EKG. And then in scenario three, you get called for an elderly patient in a facility for not acting right. You see an 80-something-year-old patient wrapped in a whole bunch of blankets who's unable to tell you anything. When you take their vital signs, you note that they're hypotensive, but they're not tachycardic, and their oxygen saturation is 88% on room air. You get a past medical history from the facility of MI, CAD, COPD, and dementia, and you note that they're on aspirin, metoprolol, lisinopril, Atrovent, Seroquel, and Namenda. So looking at this patient, it would be very easy to say, probably sepsis, they're under 20 blankets, you know, they're hypotensive. But with this patient who can't really tell you anything and has a positive, significant cardiac history, you should also be getting an EKG on them because you don't know if it's a right-sided lesion that's maybe making their blood pressure low. And you may not see compensatory tachycardia if somebody has medications on board to stop them from becoming tachycardic, such as a beta blocker or a calcium channel blocker. So again, just very important to have a high level of suspicion in all patients for cardiac disease. So let's get to some of our EKGs. So whenever you look at an EKG, you look at the rate, if it's fast, slow, or normal. The rhythm, if it's regular or irregular. You look at all the intervals to see if there's a long PR, a long QRS, a prolonged QT segment. All those are important players. And then you also look for ischemia, such as ST elevations, T-wave inversions, just anything else that looks abnormal. So in this EKG, this is normal. The rate looks a-okay. The rhythm is nice and normal. Also note that it's a sinus rhythm because there's a P wave before every QRS and the P waves are upright. There's a nice narrow QRS, which is less than typically 3 little boxes, and the QT is not prolonged. There's no ST elevations or ST depressions. So this is a pretty good looking EKG. So let's talk about signs of ischemia because it's not always that tombstone morphology. Um, any sign of ischemia could be ST depressions, could be T-wave flattening, could be T-wave inversion, could be hyperacute T-waves, which you'll see before they develop those tombstone morphology. And it can also be U-wave inversions and classically ST elevations. I know that it's very tough when you don't have a prior EKG to compare it to because sometimes people have had cardiac issues in the past and they have chronic changes, but unfortunately we don't know that when we're transporting a patient in. In this EKG here, we see a lot of depressions, notably in the leads 1, 2, V5, V6, and AVR, and V1 and V2 have elevations. So there's a lot of depressions and then some elevations. So that's most likely a subendocardial cardiac ischemic event. So very concerning. So again, your depressions in 1, 2, V5 and V6, and then elevations in AVR, V1 and V2. Going on to the second EKG, let's take a look and then we'll discuss. Okay, so the most notable thing when you're looking through here is that V2, V3, and V4 definitely don't look okay. But as a overall, it looks like a normal rate. It is a sinus rhythm because you do see P waves and there's no drop beats, there's no blocks, anything like that. So going through, we note that there are ST elevations in 1 and AVL. There are hyperacute T waves in V2, V3, and V4. And then there's a reciprocal depression in lead 3. And then also you can see some Q waves in V1 and V2. So this is pretty concerning for an anterior STEMI. And I think, with the J point elevations there, it's very indicative of a STEMI. But just in case anybody has any concerns that maybe it's just early repol, you can always do serial EKGs, and that will really tell the picture. But this is a concerning EKG overall. Let's go to the next EKG. We'll take a minute there. So going through the EKG, we definitely note that there's some ST elevations in V2 through V6. They're very prominent. And then you also see additional ST elevations in 1 and AVL with depressions in the inferior leads 2, 3, and AVF. So this is very concerning for an anterior lateral STEMI. Definitely calling that STEMI alert. Moving on to the fourth EKG. Let's take a minute here. Okay, so going through the EKG, we know that there's a lot going on here too. Looking at 2, 3, and AVF, we definitely see elevations there, but we also see elevations in V5 and V6, along with reciprocal depressions in V1, V2, and V3. So this is very concerning for an inferior STEMI, but also a lateral STEMI. Definitely, again, calling a STEMI alert. So this 50 kg, let's take a minute again. Okay. All right, so a lot of this looks a little off. Most prominently, we note that there are elevations in 1, 2, 3, and AVF, along with V5 and V6, with ST depressions in V1, V2, V3, and probably even V4. So this is a pretty large territory STEMI where it's taking out the inferior portion, the posterior portion, as noted by those very unique ST depressions in the precordial leads, and then also a lateral STEMI with the elevations in 1, V5, and V6. So that's a not great STEMI. It's taking out a few different territories there. EKG6. Go ahead and take a second. So this EKG, we can definitely tell that there's a lot of ST depressions, but the main thing I wanted to note was that there was elevations in AVR and V1, which is very concerning. AVR is easy to miss because we're not looking for the big tombstones there, but elevations in AVR are still significant. And then EKG 7, going through, looking at this again, we see a lot of ST depressions, but some other odd morphology in this EKG. So going through, we know that there's sinus rhythm. We can see the P waves. The rate starting to get a little faster. And then you can see that those QRS complexes are not very narrow. And you can see a right bundle branch blocking your precordial leads. You can also see ST depressions in 1, 2, V4 through V6, and an ST elevation in AVR. So with that, there's a lot of diffuse subendocardial ischemia with that. So again, always make sure to check that AVR. Sometimes that's not as prominent. So now I just wanted to go over some STEMI equivalents, just because they're very good to review, because they don't present like that classic tombstone, ST elevation kind of thing. Posterior STEMIs also present with ST depressions, so very important to remember that. And LVH can make it very hard to see ST elevations. So let's go first to the first example of an equivalent, which would be when patients have a left bundle branch block or they have a ventricularly paced rhythm. There's different STEMI criterias for that, which are listed on the left side of this slide. And then there's a pictorial version on the right side. It's a good idea to maybe just have these written down or have a picture on your phone of these just so you can compare because left bundle branch blocks do get difficult to read. And here's an EKG example on the next slide. So going through, we see concordant ST depressions in the precordial leads, making it scarbosa positive. But overall, looks like a very difficult EKG to read. A lot of the intervals are widened. So just something to note. The next one I want to talk about is Wellen syndrome. It can present one of two ways with this biphasic T wave kind of morphology on the left or very deep T waves that you see on the right, both in V2 and V3. Classically, these patients had chest pain earlier, but when you see them, they no longer have chest pain. And that again is a strong argument for serial EKGs because this can always change. But these patients have definitely coronary artery disease and impending occlusion. So cardiology will usually get consulted for these patients and they will get a cath. Next one I wanted to talk about was De Winter T waves. They look a little bit odd, but they're very tall and symmetric T waves in your precordial leads. So if you note that there's kind of this little ST depression and then a very symmetric T wave. I'm not sure if you can see the mouse here, but take a look at that morphology. And then there also maybe an ST elevation in AVR. So important to note because this is also an anterior STEMI equivalent. Now let's talk a little bit about interventions for STEMIs and chest pain because we see on the ambulance EKGs and aspirin, but then there's a lot more that goes on to it. So we can give aspirin if there's no contraindications. That decreases your myocardial infarction risk and mortality. So that's why you'll see a lot of patients on dual antiplatelet therapies like aspirin and Plavix, aspirin and Brilinta. Overall, then after patients get here and cardiology takes over their care, patients also usually get put on a beta blocker because it decreases your overall cardiac work and the oxygen demand so that it doesn't keep on making that infarct bigger and bigger. But it also decreases overall ventricular dysrhythmias and mortality. People also get put on glycoprotein 2B3A inhibitors that also kind of act like antiplatelets. It stops the platelets from sticking together. Heparin stops thrombin from forming and functioning. Nitroglycerin decreases your cardiac workload. ACE inhibitors decrease your chances of developing heart failure and also your mortality with any sort of cardiac event. And statins work short-term and long-term to kind of stabilize those plaques within the arteries so that you're not continuously throwing plaques down and reinfarcting. And then your interventionalists can do PCIs, CABGs, anything to kind of do that definitive management of whatever their cardiac disease is. Let's go over some ACS mimics briefly. So just because somebody's having chest pain and there's no big heart attack, they could be having a lot of other diseases that are causing chest pain, such as arrhythmias, heart block, pericardial effusions, which is fluid around the heart. And sometimes that leads to pericardial tamponade, where the heart's getting squeezed from the outside so it can no longer really function. You can get pericarditis, which is inflammation of the covering that surrounds the heart. You can get pulmonary embolisms, which also can cause chest pain. You can get a pneumothorax, which can also cause chest pain, along with pneumonias, aortic dissections, esophageal ruptures, which is a hole in an esophagus. So if somebody has been vomiting severely or in a traumatic event, they may have a tear in their esophagus, and then there's air that is going into their mediastinum. So you may hear odd crunching noises, but that can also cause a lot of chest pain, and ruptured peptic ulcers, which lead to free air in their abdomen, which also will push up on those diaphragms and cause some chest pain. So important to note that just because it isn't the heart doesn't mean that it's not something serious, and there could be many other pathologies. And then lastly, I just wanted to briefly talk about young people and heart problems because it is very scary when it happens. Kids shouldn't be having heart attacks, shouldn't be dying from cardiac disease. So I just wanted to touch on these briefly. So a lot of the underlying issues that kids can have could be hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, Brugada, long QT, WPW, and cerebral T waves. Long QT syndromes are the QT interval is prolonged, which makes them very prone to ventricular dysrhythmias and sudden death. So if you see an EKG with that, bring it to somebody's attention. So hypertrophic cardiomyopathy, or some people call it HOCM, is a cause of sudden death in kids. The usual board story is somebody's playing football and then all of a sudden just drops and they're in cardiac arrest. What you'll note on their EKG is LVH and Q waves in your lateral and possibly in your inferior leads. So this is very weird. You shouldn't be seeing Q waves. You shouldn't be seeing LVH in a teenager. So that should raise your suspicion. And basically what happens in this pathology is that their interventricular septum of their heart, the middle piece that goes down the inside of their heart and divides like the right heart from the left heart, that's thickened. So it leads to outflow obstruction. So when their heart's trying to pump blood out of the heart to feed the rest of the body, it can't do that very well. And these kids may have initial events of when they're working out, they'll have syncopal episodes, but then it can also lead to sudden death. So in any of these cases, it's also very important to take a look at that EKG, but then also to ask a family history if anybody had passed away suddenly in their younger years. Arrhythmogenic right ventricular dysplasia is another one. It's kind of a little odd. But what it is overall is that in their heart, they're getting fatty infiltrates in the right side of the ventricle. And this leads them to ventricular dysrhythmias. And then they can go into heart failure and also have sudden death. So what you'll see on their EKG is that they have a right deviated axis. So you see that the QRS is very tall in AVF and pretty negative in one. So they have a right-sided heart deviation. You'll see a predominant R wave in V1. You'll see this weird little epsilon wave. Again, if you can see my mouse, if you can't, I will describe it. But there's this little notch on the end of the QRS complex. You can see it really well in 3 and AVF. And then you'll see widespread T wave inversions. This is also very important to bring to somebody's attention, especially if you have that teenager who just passed out basketball or what may have you, and now they're awake, but their EKG doesn't look quite right. And then we have Brugada here. This is a sodium channel mutation that predisposes people to sudden death. So there's a few different types. This one is the most prominent if you look in V1 and V2, how there's this very big up and then down kind of ST segment. You will see classically the ST elevation with the inverted T wave, but then also you can have like a saddleback kind of morphology, and then you can have a mix of the two. So these kids also are predisposed to sudden death. Um, and sometimes other illnesses or drug use can also bring this out in somebody's EKG. So very important to take note of this. And WPW, these kids can be fine, and then all of a sudden they can get tachycardic, and then they can get very tachycardic. It's basically a congenital accessory pathway. So in their heart, instead of the electrical conducting system going one way, there's a bypass, and that heart can conduct through multiple ways instead of just the normal way with all of its normal checks and balances. So what you'll see characteristically on their EKG is a prolonged QRS. So in a kid, you're like, that's kind of weird. The QRS shouldn't be prolonged. The PR interval will be really short. Those P waves will be right next to that QRS complex. And then you'll also see a delta wave, which is where you see that kind of the upslope of your QRS complex is a little bit slurred, a little bit broad. It's not as crisp as you see on the downslope of your QRS. Then I want to do over cerebral T waves because we do see a lot of trauma here. This is indicative of increased intracranial pressure, such as bleeds. So you see these very deep T wave inversions, and you'll see a prolonged QT interval. And then let's just go over triage. I know that we just did this in some of the medic competencies, but just some things to think about. Always get a full set of vital signs. Make sure to take a good history and physical exam, paying attention to medical conditions, prior history of heart attacks, home medications, especially the ones that kind of point to somebody having a cardiac condition, and then any social history, such as have they been smoking for at all? Do they use cocaine? Do they use methamphetamines? Do they use anything that could predispose them for earlier cardiac disease? Give them aspirin if there's no contraindications to giving them aspirin. Use extreme caution with nitroglycerin because if there's an inferior STEMI, you will decrease their preload and they will no longer be able to maintain their blood pressure. So overall, maybe don't give it. Also, don't give any nitroglycerin if they had recent sildenafil use or if they take any of the medications for pulmonary hypertension because those are in the same class of medications. ALS should be getting an EKG for any complaint in the chest and abdomen, any shortness of breath, and in patients especially 40 years or older. But again, if you have any of those cases where somebody's complaining of chest pain, it's always good to get an EKG. You take serial EKGs if needed. You may catch some subtle changes of somebody developing a STEMI, and then you'd be able to call ahead and expedite their care. Treat dysrhythmias as per your protocol. Again, call ahead for any STEMIs, and when in doubt, call medical command. They'll always be happy to help. There are my references, and if you have any questions, please let me know.